80 hours on that you need to be associated with, the overall monitoring parameters as well, what you really need to watch out for. Anything you want me to review? No? Okay. Oh, before I forget, as a quick announcement, Dr. Teeter is attempting to make sure he gets grades either up by this evening or by the latest tomorrow morning for you guys, so you'll all know by tomorrow morning. So, I wish I could tell you they were done, but he did have a note on his door not to disturb him today because he was heavily going through each and every one of your exams individually, so that's why it's taking a little longer than expected, making sure that you guys get every point possible that you're supposed to get, all right? So, for those of you that did have the chance where your grade came up before we realized that that was inappropriately unblocked from you and saw your raw score, please be aware that there were several changes because they were not scoring correctly. So hopefully that'll calm some of your freak out mode before tomorrow when they're posted. Or this evening, who knows. Okay, so getting started for today, we're going to start out with carbamazepine. You guys have probably heard of this drug before, especially in pharmacology, as being one of those drugs that in terms of its overall side effect profile, it has, as many of the other AEDs do, anti-epileptic drugs do, a lot of side effects, but particularly because of its auto-induction and induction of other drugs. So what I mean is that it's heavily going to induce many other drugs that are going to be metabolized by the CYP3A4, 1A2, 2B6, any of the major CYP isoenzymes. It's going to induce most drugs that go through that pathway. So a lot of the time, even when you're thinking of a drug that, say, has two different CYP isoenzymes, for example, if we have a drug that's primarily metabolized by 3A4 and 1A2, we don't normally think of in terms of drug interactions as that being as much of a problem, right? Because it's got two different pathways. You guys remember learning that? If it's got one primary pathway, it's much bigger risk. Well, unfortunately, carbamazepine induces all of them. So even at times those drugs that you're looking at as not being as much of an issue, it will be with them overall, okay? The other interesting thing is, and we'll talk about this a little bit more, is it induces itself. So that can be a problem, obviously, when you start giving the drug, and we'll go through what you need to know about that as well. All right? So overall, in terms of treating bipolar disorder, carbamazepine is one of those drugs that we do see commonly used for mania, acute mania, and just as a mood stabilizer overall, even in our bipolar II patients. And one of the things that, in terms of prophylaxis, when you're comparing them, we relate to lithium a lot, we relate to valproic acid a lot as kind of being our first two major ones. So carbamazepine has definitely got efficacy there as well. And, because of the drug interactions, it may prevent you from using it in several people. But it's not to think that, depending on the patient's specifics that you're looking at overall, this may be more of a favorite option than the first two we've discussed. So again, it all comes down to patient specificity. Time to response can be similar to comparison to the other ones, up to 1 to 3 weeks. So kind of going off of one of the quiz questions that you guys had specifically in those drugs that can treat sometimes quicker, you remember the class of medications that tend to work a little bit faster than, say, our anti-epileptics and lithium? Antipsychotics. So out of your answers, you had one there, so that would have been what you would have chosen, right? So I believe that one was Risperdal, I want to say. So your time to response overall can be up to 1 to 3 weeks. Similarly with some of the others, it can be 1 to 2 weeks, 1 to 3 weeks can be more. And typically when we're looking at our antipsychotics, we'll talk about that a little bit later in class as well, that usually you can start seeing a response sooner, usually within a week in many of those patients. Okay? A lot of the time when we're looking at our adjunctive therapy, that's why we'll use them as well. So 1 to 3 weeks for carbamazepine. Looking at our dosing and monitoring, we're usually going to start always out at 200 milligrams to 400 milligrams per day, splitting the dosages up, again, to hopefully minimize the side effect burden. We also have the controlled release of this drug, Tegretol XR. If you're using it for, I should mention, for bipolar, it's actually marketed with a different name. The brand name is Equetro. Okay, so synonymous obviously you're looking at the active drug being carbamazepine. It doesn't really matter whether you're using dextrose, hydrotol, carbamazepine, all same thing. Doses are going to be the same for all of them. Okay. Every 3 to 5 days, you're going to increase the dosage up to 600 to 1200 milligrams per day in divided doses. Plasma concentration ranges you need to know because of the toxicity levels, especially when you get above 12, is ranging from 4 to 12. Okay. This one is known, as you can imagine, with the metabolism to the liver that it affects. It's definitely hepatotoxic, so that's so important. And then when you get a dosage above 12, kind of similar to all your other anti-epileptic drugs, you'll start seeing a lot more of say the ataxia and the neurologic issues that can be associated with them with overdosage. Okay? Steady state is 5 to 7 days, so if you're going to draw a blood level, you want to remember a minimum of 5 days. And then what you're going to do for 2 months after that, every 2 to 4 months is necessary, but especially after about 2 to 4 weeks, you're going to make sure you're monitoring very closely those levels because of the autoinduction. So it actually can induce itself and levels will drop by half. So again, you want to make sure you're not having efficacy be compromised because you're not giving an adequate dosage at that point, and you often are going to have to increase the dosage. Okay? So kind of a funky way to think of a drug that, it induces itself and we're going to have to bump up the dose after they might even be something close to stabilized, but that's what we need to do with carbamazepine. Okay? Similarly to the other drugs we talked about, for example, like lithium and valproic acid, you want to make sure you're drawing a level at least 12 hours post-dose, or more than that if you're giving an extended release and every once-a-day dose at your trough levels. Okay? Of course, that's important. When we're looking at our monitoring parameters, as I kind of mentioned, LFTs are going to be essential in looking at this drug. It can cause some hyponatremia. Interestingly enough, if you're looking at oxcarbazepine, remember we talked a little bit about that last time. Again, though that doesn't have the FDA approval because of the fact that it doesn't have the autoinduction and the side effects overall are pretty low. The one difference I would say with trileptal that you'll see is that trileptal has a higher incidence of positive hyponatremia, okay? Where carbamazepine does as well, but for whatever reason, trileptal will have a higher incidence than that. So we need to be monitoring that as well. Electrolyte abnormalities, you can of course monitor that. Looking at your overall, complete metabolic panel and your Chem14 basically, and you're going to monitor those. Looking at the history and physical, of course, with all our citations, I kind of go without saying neurological assessment because this is an anti-epileptic drug. Similarly to valproic acid or lamotrigine or any time you're using an anti-epileptic drug, you stop that drug, you want to make sure you're titrating back up, and you know that, and the patient knows that because it's an anti-epileptic drug and you get stabilized with medication, even if you've never had a seizure before and you stop this medication, it does raise the potential to have a seizure. It decreases the seizure threshold and you can stop the medication, okay? So you've got to do a full neurological assessment and make sure when you're counseling your patients, they're aware of that, okay? And an EKG as well. We'll go over that a little bit more, why those are all important. So neurologic, this one has a lot more neurologic side effects than some of the other drugs we're going to talk about. The drowsiness, dizziness, delirium, diplopia are definitely something we see much more commonly in these patients. Gastrointestinal, similar to other drugs, helps if you take it with food because the GI effect can be pretty hard on the stomach with nausea, vomiting, and some diarrhea. And up to 15% of patients, more so it's the nausea and vomiting than anything else. Okay? Dermatologic, you can have some rash and some photosensitivity reactions that can occur. So you want to make sure you're counseling the patient that if they're having, a lot of exposure to the sun, that photosensitivity reaction can be an issue. Okay? Hepatologically, you do have to have concern to warn your patients of what to watch out for in terms of liver injury. So 25% of your patients are going to have some transient increases in their liver function tests. Okay, I'm sorry, this is hematologic, we're talking about hepatologic. But about 25% I should mention as well for the hepatologic will have transient increases in LFTs. Hematologic, as I kind of mentioned, you can have some effects, this is why you have to monitor your CBC. So you've got your agranulocytosis risk and your aplastic anemia risks that are pretty darn low, but because of the fact that they are going to occur, how severe they are, you're always going to make sure you're doing your baseline and follow-up monitoring. Okay? This one, kind of the opposite of lithium, can cause transient increases in white blood cells. So where you're going to have to worry about increases in white blood cells with lithium, carbamazepine can transiently decrease them. Now, lithium, if you were to take it long term, it'll continue to have the levels of white blood cells remain high. Where this one, after the patient stabilizes, it'll usually return to normal. Okay? Again, the hyponatremia is rare, but you want to make sure you're monitoring for it. The pregnancy and breastfeeding, again, this is a category D. We know that this causes teratogenic effects, especially within the first trimester, so if the patient doesn't know that they're pregnant, this can be a problem, and you'll make sure that they're very closely monitored throughout pregnancy because of the congenital malformations in the fetus. In terms of drug interactions, it does mostly affect CYP 1A2 and 3A4. Though it can affect some of the other CYP isoenzymes to a lesser degree, okay? Again, it can increase the metabolism of the drugs and itself. Remember that autoinduction. The result is a decrease in the other drugs' blood levels overall in most cases, okay? Especially because of the fact that many of our primary therapies are going to have 3A4 as a major pathway. For example, birth control pills, antibiotics, other anticonvulsants, and anticoagulants are going to have an issue in terms of drug interactions with many of them. Especially something like birth control pills, where a lot of the times if you're giving a drug like this, you almost want to make sure that the patient's not going to become pregnant on the medication. It can cause contraceptive failure, so you have to make sure you're treating with high enough dosages where you would expect it to be a response, and usually using a second form of birth control. Okay? The interesting thing with the interaction of phenetone and primidone, much more to a reaction with phenetone than primidone, but it can actually increase the levels of phenetone. And primidone, there's been some reports with the barbiturates in general. There might be some interaction there, but I want you guys to circle phenetone. You don't have to worry about the primidone interaction as much. Okay, there's some mixed reports on the primidone. Okay. In terms of our next drug now, lamictal. So this drug, in terms of treating seizures, is one of our neurologist's favorites. It is one of those that, for treating seizures in particular, you'll see kind of, because of the fact it has lower side effects overall, and as long as you're titrating the dosage properly, many times you don't have to worry about one of the major side effects of being rash, though that's always a potential, okay, that this drug, in terms of bipolar, in treating the depressed phase, has been found to be much more beneficial than keeping that patient stabilized. So lithium and lamictal, in terms of treating bipolar 2, are the favored maintenance therapies if you're looking at maintenance therapies, not acute therapies as much when you're looking at lamictal for mania especially, but the depressive side has been found to be much more favorable. Okay? Does everybody have questions on that? Are we okay? All right? Okay. So it is FDA approved for the maintenance of bipolar 1, but again, don't think of it in terms of acute mania. It's not something if somebody's coming into the hospital and looking at it as a first line. It's not to say, kind of like what your article alluded to, that if you have somebody who's, say, bipolar 2 or bipolar 1 and you're going to use it, if you're concerned about switch rates, this mood stabilizer has got more efficacy to make sure that the patient's not going to go into the depressed state as much. So more so for, again, the bipolar patients, we can see efficacy. Okay? Remember, for maintenance, prophylaxis is probably its best place. All right? If you do have somebody, again, that is acutely manic, think of it as adjunct therapy, not a monotherapy. Maintenance efficacy has been shown over a lot of studies from 2 to 18 months after acute stabilization, that the relapse to cycles, whether it's going into depression or mania, it's prolonged. So that's good for hopefully prolonging it or avoiding it altogether, going into another cycle, right, if it's really doing its job. The big thing you have to remember is Stevens-Johnson syndrome with the drug, okay? And one of the things in terms of the rash with this drug is that If you have a patient that develops a rash, it's usually going to occur, and it's much more common to happen in the beginning phases of treatment. So when you start the drug out within the first couple weeks, or when you're titrating the drug after you've been stabilized to a higher dosage. It's much more common in our pediatric populations than in our adults. But the thing you have to remember is that once the rash appears, you usually are going to discontinue the drug and switch to something else because of the risk if you continue it despite the rash, that it could potentially increase your chances of causing Stevens-Johnson syndrome. So Stevens-Johnson syndrome is a really horrible thing. I can tell you with patients that I've seen develop this, that most of the time it's been associated with specifically low mental therapy, that they haven't recognized the rash and continue with therapy despite that. And again, because of the higher incidence in children, most of the patients I've seen is pediatrics. And some of the dangers of this is what it is a sloughing of all the mucosal membranes in the body. So you can imagine that can cause blindness, it can cause havoc in the GI tract, and obviously the skin itself will start peeling. Okay, it's really, really painful. It's an awful disorder. So when you do start seeing the rash, just make sure that you would caution your patients ahead of time that, make sure you see the physician at that point, and you're usually going to change therapies. Okay? Just make sure you're noticing it early and that you're having the patient follow up. All right? It's usually within the first couple weeks of therapy. But again, it can be at any point that you're increasing the titration up. It's much more common again, usually within the initial titration period of getting up to a maintenance dose. Okay. Also, some common side effects that the GI side effects again can be pretty well managed with food. You're going to start out the patient generally recommending this. You can, start dosing it at bedtime to alleviate some of that if that's going to occur as well. The others, insomnia, headache, somnolence, back and abdominal pain, fatigue, and rhinitis are usually pretty transient. Those will go away if they do occur as a side effect within a short period of time. Okay. The dosing schedule that you see here is specifically because of the rash more than anything else and the risk of the Stevens-Johnson syndrome. So you guys have to know the dosing of this drug. You're going to start out, in most cases, at 25 milligrams. If you're giving it with valproic acid doubles the dosage of this drug. So you're going to give it every other day as opposed to every day starting out. And it'll always be half of what you would normally give for an average dosage. If you're giving it with another enzyme-inducing anti-epileptic drug, like you see listed at the bottom there, your carbamazepine, as we, of course, just talked about, phenytoin, phenobarbital, and then primidone, which is basically the parent drug that breaks down the phenobarbital. Okay, so that's kind of the same thing. If you're giving it with any of those, you double the dosage because of the fact that it's going to half the dosage overall. Okay? Doesn't matter which one you're using. You're going to make sure the Rasprish is across the board, usually within the first couple weeks of therapy, okay, until you get up to your average maintenance dose. One of the things that you need to be aware of is that we highly recommend using the starter packs to make sure the titration is done appropriately. So you'll start out with these specific starter packs. So this is the regular one, starting out with, say, 25 milligrams per day, and then slowly increasing it up. If you have valproate, it comes in a blue pack. I kind of showed that when we were going through valproic acid a little earlier as well. And again, that has the dosage basically cut in half, where instead of 25 milligrams to start, you're going to do 25 milligrams every other day. And then we have for our enzyme-inducing drugs, the green pack, that basically, again, carbamazepine, phenytoin, and phenobarbital. Right? So it's really, really important to make sure you're familiar with that. A lot of the times, patients aren't going to know that risk, and as pharmacists, this is definitely one of those drugs you want to be well acquainted with and make sure you're monitoring for, because it doesn't always come up on the top of many physicians' minds as being an issue as much as it's going to be if you're not titrating appropriately. All right? Kind of similar when I mentioned Topamax to you guys. If that one's being used, these drugs that tend to have some patients or some physicians not want to use them as much, it really is about, with all your anti-epileptics, that you have the potential to use starting out low and going slow, okay? For example, you guys will hear at some point again, you guys have ever heard the drug Psychopharmacology pyramid, besides when I mentioned it? Does anybody know what the nickname for that drug is? Psychopharmacology. Any idea why? It actually is known to cause cognitive impairment. So for example, I can tell you with some of my migraine patients that I've seen, we'll start them out on this because it's very effective in migraines, but they'll might be treating the migraine attacks that they're having and they're not noticing those anymore. They don't really care about anything else. They kind of like lose interest in everything. Again, this is if you're titrating it too quickly, but it causes major cognitive impairment on the medication being used. So that's why it's called Dopamax. Okay. So if you ever hear somebody similarly with Lamictal, Topamax is the other favored one in terms of neurologists now for treating seizures, and then again off-label in bipolar patients. So we're not going to go over it as much. But start out low, go slow. You can usually avoid number one, the rash with Lamictal. Number two, the dopey effect that Topamax will cause. So hopefully that'll help you remember that when you see the drug again. Okay. In terms of atypical antipsychotics now, the FDA has approved as monotherapy or adjunctive therapy these agents in terms of other mood stabilizers. We're still looking at our lithium, our carbamazepine, our valproic acid, or our Lamictal as often our mainstay of therapy for first line, and looking at these as adjunctive agents if the patient's first coming in as manic. Okay? And not to say in terms of our bipolar 2 patients that we wouldn't consider lithium and Lamictal are kind of the two that we normally think of, but there's some results showing that you could potentially, if you just wanted to try monotherapy because of less monitoring, or that just happens to be favored choice. For example, if you're using Seroquel, that we can use them as monotherapy. They do have that approval. Again, initially starting out, a lot of the time you're going to use it as adjunctive therapy. Okay. Kind of similarly, when we talked about schizophrenia, all the same side effects apply. And we're actually going to go through a slide. We're heading towards discussing all our antipsychotics as a whole. There have actually been studies in specifically bipolar patients separately from schizophrenia, and the side effects, though you would expect overall they're going to have the same side effect profile, there's a higher incidence of some in bipolar patients versus schizophrenic patients. So we'll kind of tailor down what those are when we get to that point. So we have shown that the atypical antipsychotics as a whole, when we're using them, have significant symptom improvement seen in 3 to 7 days. So again, going back to that quiz question you guys had, these can have results shown a little bit faster than our other agents like the lithium, Lamictal, carbamazepine. But again, because in acute mania, they may not have as much of a positive role of really bringing the person down by themselves as if you were to use one of those other agents. That is why you see more time they're in adjunct therapy to that. Okay? The consensus guidelines, the expert consensus guidelines, they've come out to include them as first-line agents, and that kind of got the ball rolling with a lot of the dual indications that you'll see not just for schizophrenia but in bipolar now too, where they were originally marketed as just an antipsychotic, that they now have the dual indication of a mood stabilizer. Okay? In terms of bipolar depression, they're still doing a lot more studies because there's always been more of a focus on the manic side of the disease as opposed to the depression side, because we know we have a whole slew of agents in terms of our antidepressants, how to effectively treat that. But the problem is that people don't look at the bipolar illness a little bit more long term, of making sure we're preventing them from cycling through. So there still needs to be some more research in these agents compared to, say, our lithium and Lamictal Okay? So, as I mentioned, tolerability of atypical antipsychotics and bipolar disorder. This study came out, and actually it was great that they did this because, again, we don't want to just kind of lump in the drugs with our schizophrenic population using them, since it is a very different presentation when you're looking at the overall illness. So you can kind of notice among those that have the approval here in this study that olanzapine, in terms of weight gain and sedation, are very notable to make sure you're watching out for that drug. And again, that doesn't hold out the effect from cardiovascular complications long term, right, that metabolic syndrome can cause in a patient, of course. But the waking and sedation are the two in terms of your bipolar patients that you definitely are going to see much more of that side effect be apparent. In terms of extrapyramidal symptoms, Risperdal, as you would kind of expect, remember we talked about when we discussed it in schizophrenia, is the strongest dopamine 2 binding agent of all the atypicals. So you basically would expect overall that, I should say the atypicals that are specifically approved in bipolar, because there are a couple that are close to it. But in terms of treating bipolar patients, we do see that one among all kind of stand out for showing EPS. Okay, Ziprasidone across the board, much less of an effect, but unfortunately, that drug in terms of clinical efficacy, we don't tend to see as much of a positive effect as we do some of the others. And that's just speaking from a clinical opinion. Some studies are kind of lacking. They do have some positive effects shown, and I'm not saying that I haven't seen patients that haven't responded to therapy, but it doesn't, among all the atypicals, jump out as my favorite option starting in the first time treatment because its efficacy. I personally, and many psychiatrists and much of the literature says it just doesn't have as much of a bang for your buck compared to some of the other atypicals. Okay, Quetiapine. I have sedation circled there. The waking is another one that you'll see 2 pluses there. I didn't circle that as much because I would say in the majority of the patients, you're definitely going to have those patients complain of sedation more than anything else. Sometimes you want that. There are bipolar patients, right? Especially if we're looking at mania, that we want them to kind of slow down. So that's typically why they're going to complain probably more sedation with that drug than the other side effects. Again, if you remember your A to Z mnemonic of metabolic syndrome, it's right below Zyprexa, so you can expect the metabolic side effects to be higher with that than some of the other choices for you as well. Okay? Clozapine, we know the awful side effects that clozapine has. The waking, sedation, about the same as you would see for olanzapine. So remember, because it's treatment refractory, you're kind of sticking it right at the end of the line as well, in addition to the olanzapine there for metabolic issues. But the sedation with that one as well tends to be a little heavier than with some of the other therapies. Okay? The aripiprazole. Aripiprazole, in terms of GI side effects, please make sure you pay attention to that because it's one of those that is sometimes, remember I mentioned aripiprazole will typically give in the morning because it can be more stimulating. For whatever reason in our bipolar patients, sometimes you will see a little bit more of the sedation profile than you'll see in the schizophrenic population, but the GI side effects tend to be their main complaint with that drug. So a lot of the time we're going to recommend they're definitely taking it with food, and you want to remember this drug has a very long half-life. It's over 40 hours. So even if you were to give this drug every other day, not that we would want to recommend that because they can find it out the window, but because of the long half-life, as you can imagine, when this drug peaks, you're going to see more of that side effects, and even throughout the day, you'll recommend the patient don't go into the stomach. Small meals throughout the day will really help out, especially if the patient starts getting used to tolerating the medication in initial therapy. Okay? So, kind of looking at our, again, clozapine therapy, it is indicated for treatment-resistant schizophrenia and bipolar, as we talked about last week. We really are going to reserve this as last line as we did in schizophrenia, maybe probably even more so than schizophrenia because of the fact that in terms of schizophrenia, you know, with the disease itself in terms of our therapies, you may only have specific options that you can kind of go to, or with bipolar, with the polypharmacy that you're already going to be implementing, you've got a little bit more leeway, okay? It does have, again, the unpleasant side effects. Please keep those in mind as we're going through. The drooling, the waking, again, the seizures being the higher the dosage you go to, the higher the risk. Remember, if you're above moderate dosage, usually above 600 milligrams, you do have a good percentage of your patients that it's going to lower the seizure threshold. And remember, I had mentioned there's certain institutions that actually are prophylaxed because it's over 10% of patients at the higher dosages that will end up having a seizure. So definitely something in terms of if they stop therapy, if it's more than 48 hours, you have to do a titration, specifically more so for seizure risk than even the catering and psychosis. Okay? Again, remember the cardiovascular effects, keeping in mind that you have those eosinophils ridiculously in the thousands, that, you know, if that's very high. They won't be showing so much a sign of allergy, but it puts them at a higher risk for the sudden cardiac death. Okay. Again, the metabolic issues, so the diabetes is way up there with this one. Orthostatic hypotension is another one with this one. So all the same side effects that you've got about apply here, remember them, okay? The other thing is, again, the costly lab monitoring with this drug, having to do the Cosmo National Registry, whether you're schizophrenic, you're bipolar, doesn't matter, same doesn't apply. And that you have to start your patient out, remember, weekly blood draws, and even after 6 months, it goes every 2 weeks. So that's pretty burdensome, okay? In terms of the next drug here, again, remember, risperidone. So clozaril, remember, came out in it was originally developed in the early 70s and kind of wasn't used so much. And then in the 90s, when risperidone looked at it, it was kind of saying, okay, these are our newer atypical drugs. Schizophrenia kind of got the ball rolling with this. But again, the risperidone, when they started noticing it in terms of when they were treating bipolar patients having the efficacy, definitely was one of the reasons that all the studies for the other antipsychotics that are used on why that happened. The initial dosage, you're going to start out a little bit more conservatively when you're dosing for the schizophrenic patients as well. Because the average dose is usually 4 to 6 milligrams here, we're talking about schizophrenia, we're usually up to 8, okay? And you may even start lower than the initial dosage of 2 to 3 milligrams in these patients, depending on their initial response to the drug. This one, you're still generally going to recommend BID dosing, though, again, you can give it daily because of the fact of it having almost a 24-hour half-life, about 21 hours. When you do have those patients that are complaining of sedation, that might be more so when you'll give it daily, especially to help out with compliance. But you still run the same risks of giving it daily instead of BID with the higher peak, having higher chances potentially if it's going to occur. Much lower than, say, if you're going to do typical, but watch out for those peak side effects, okay? Again, the Risperdal Consta, I should mention to you guys that they have developed a 12.5 milligram Consta dose. We're usually going to start patients out on 25 to 50, that's why I've got that listed up there for you. So it is available in 12.5. You're usually started at 12, or the 25, okay, then you'll go up to 37.5, and the maximum is 50. Above that, we haven't seen any real benefit in terms of our therapeutic response above 50, besides showing more side effects. The 12.5 milligrams will sometimes be reserved more so for our elderly patients if we're going to use it, as opposed to our adult population, which don't have a problem. So right out in 25. All right. The same side effects in terms of drowsiness and somnolence you would expect. One of the other reasons that we'll give a BID is specifically because of the orthostatic hypotension, so keep that in mind, that you're going to counsel the patient on that. Watch out for dizziness if they're standing up too quickly, if they're not passing out right away upon that. Again, this drug, the higher the dose, the higher the EPS risk. So when we're talking about our bipolar patients, so I did show you guys that you do have more complaints of EPS with this drug compared to all the others. It really is depending on the dose. The lower the dose, the lower the chance. When you get up to higher doses, especially in bipolar, more so in schizophrenia, we've observed that 6 milligrams, and definitely when you go higher than that, that'll be more of an issue. The medium weight gain, kind of what you would expect if you're remembering your A to Z, does hit our adolescent population, similarly like when we talked about Zyprexa. Our adolescent population is a little bit more prone to weight gain with this, which is interesting because of the fact that you need to know our adolescents are typically, if we're going to use an antipsychotic, one of the first-line therapies is going to be Risperdal because it's approved in our adolescent population first. This drug, and remember I mentioned in schizophrenia, it was approved in treating behavioral issues in autistic children. So because it was first approved in children, this is very, very common to see used within our adolescent bipolar patients. There's a comfort level there because those studies haven't been done, at least in pediatric patients, where many of the drugs are lacking. Okay? Zyprexa.
So, again, same risk as in our schizophrenic patients. That warning is you're using in adolescent patients, much higher risk of causing metabolic syndrome issues and weight gain, and that being part of the black box warning, and the diabetes issue. So we really, really want to make sure, again, in our adolescents, we're paying attention to that with Zyprexa. This is kind of nice one in terms of treating an agitated patient. It comes in a lot of different formulations that for bipolar, for patients manic, you can remember, since it's an atypical antipsychotic, 3 to 7 days you'll see a little bit more of an effect with these. That I might have somebody just temporarily to kind of get them stabilized on a lithium dosage. I know I don't want to look at Zyprexa potentially as much as the long term, but as initial therapy as an adjunct, I might be looking at this to kind of get them stabilized. It does come in an ODT tablet, orally disintegrating tablet. It comes in an IM injection, so you can give that for agitation right away. And then you can stabilize them on the regular oral dosage form, and again, it even comes in the Zyprexa Well Prep. So it might be something that initially within the inpatient acute care unit that hopefully we get them kind of stabilized down after a week or so, and then may or may not continue to have that adjunct therapy when they go outpatient. But you can't give somebody a dosage of lithium for acute aggression, hostile behavior, where you can do that, say, with the Zyprexa. So that's why you'll see that sometimes just used as an as-needed, instead of the other options, which would be like our B53 or our typical agent, like our Haldol, Ativan, Benadryl. Okay. This you commonly will also see if it is given in an IM injection, that you're usually going to give it often with a benzodiazepine as well, so you'll still see that given with Ativan. It's important to know as a pharmacist that you guys cannot mix them. Some drugs you can draw up in the same syringe. You cannot mix anything else in the Zyprexa. This basically comes in a reconstituted powder that when you put it in and shake it up and it dissolves, you're not going to mix anything else with it. Okay. Some of the other drugs you can give, again, you can draw it all up in the same syringe. So really important, and one of the questions I can tell you in terms of nursing that I had more often than not, it'll be something along those lines. What can I draw together? You don't really want to have to stick an aggressive patient more than you need to, right? So the less needles in your face, the better. It is, in terms of combination drugs, the only one that's available with an antidepressant, so specifically for our bipolar 2 disorder patients, Symbiox, which is olanzapine again, and fluoxetine. You're only going to obviously use this in bipolar depression. You're not going to be using this, obviously, if someone's manic, because the Prozac that's in there is probably just going to make them go more off the wall than anything. So please remember it's only in bipolar depression, as you can probably suspect with the in here. The typical dosages, you're usually going to start out on the lowest dose of 6 milligrams of Zyprexa and 25 milligrams of Prozac, the fluoxetine, and you'll slowly titrate up. You'll notice that when we were talking about the Zyprexa, your dosage range is 5 to 20 milligrams. So when it comes by itself, it starts out, you can't actually get it in, you can start out in, say, 2.5 milligram in certain patients if you want to start out really low, especially if you're elderly population again. So it all goes in usually by 5 milligram increments. When you're thinking of Symbiox, kind of remember that it goes into 6 milligram increments. So they kind of did that so you wouldn't be looking at it as an equivalent to just say, I'm going to give 5 of Zyprexa and 5 of Prozac. They want you to use their branded products, right? So not to say that in practice we may not do something similar and look into that ourselves. Okay? Seroquel. So Seroquel, remember, in terms of our therapy, has been shown pretty effective in our bipolar 2 depressed patients. Not to say we can't use it in mania as well. But if I am going to be using a medication in our bipolar depressed patients that's an antipsychotic, that this is one of my favorite ones because the studies are showing that it's got a good amount of efficacy, stating it helps with that. This, again, remember, because of the fact probably of it being a clozapine analog is you have pretty much no chance of causing EPS. And I don't want to say no chance because There have been some rare reports, especially in your children. I can tell you specifically autistic children, for whatever reason, will sometimes use Seroquel or Clozaril, pitocin or clozapine in those patients because of the fact that they're more sensitive to EPS side effects. And it's kind of interesting that in that population you will see that happen. But again, you really shouldn't overall have to worry about EPS with these drugs when you are using them. It is a positive analog. So half-life overall is about 6 hours, remember. Can be longer in elderly patients. The extended release, you can give it once a day. Because of the release, even though it says half-life is 7 hours, you can give, again, the extended release once a day, and that is actually the formulation that's preferred more so because of the approval, and that's the studies that were done for bipolar, were with the extended release. So whenever possible, we're starting out at 300 milligrams and titrating up, to what they say is a max of 800. Similar supply to when we talked about schizophrenia for potentially going up to 1200 clinically. But you guys can remember more so in bipolar, you're starting out with the XR formulation, and you're titrating usually up between 400 and 800 milligram doses per day. Okay, so if you're remembering overall the usual dosages, you can remember if you're giving it with the immediate release and you're giving it say 3 times a day. You're going to start out then probably at 100 milligrams CID versus the XR 300 milligrams a day. Or if you're looking at still giving the immediate release because you want to feel like some patients actually like to take their medications a couple times a day. I actually, had some cases of more of when you get into your access 2s. You guys remember access 2? What is that again? Personality disorders. For some reason, you get this flavor of borderline personality disorders and bipolar meshing together often. And if you have somebody that's an access 2 borderline, they like to take medications. It makes them feel like, they've got something to complain about. I don't know. But you'll see a lot of the times that in our borderline cocktails, we'll call it, in our bipolar patients, they'll be on everything. They'll literally be on, like, your antipsychotic, your other mood stabilizer. They'll be on like 10 drugs, and they're probably, in terms of their presentation, not that different than someone that doesn't have that borderline flavor. But we will sometimes give those specifically a couple times a day because of those types of patients that they'll prefer the immediate release. Okay? The higher doses, as I mentioned, can be pretty well tolerated. So when you see some patients, again, going up to 1,000 milligrams, 1,200 milligrams, just keep that in the back of your mind that clinically we're okay with that overall. Okay? So, Geodon. Similarly, as we talked about with schizophrenia, there's not too much difference here in terms of obviously your drug profile for drug interactions, same side effects apply. This one, again, remember, does have less of a metabolic issue. The weight gain is pretty minimal in most cases. And the metabolic syndrome of, say, the blood pressure, the hyperglycemia, all that, not as much of a problem. Still going to be doing the baseline EKG because of the QTC prolongation. So if anything else, we're going over this again in a few moments for the second time. It'll make it that much easier when you're studying, but most of it's going to be pretty similar with whatever disorder you're treating, if it's the bipolar or schizophrenia. This one we do like with the fact in our bipolar patients. Similarly, you're going to hear me talk a little bit more about this in bipolar than even schizophrenia. Again, the IM injections are available. So if I do want to stabilize somebody on this drug, that's a nice way to start out. If I have to use it for aggressive behaviors, I can give them an IM that's available. I don't have to use something that's not, like, say if I'm giving Risperdal. Risperdal doesn't come in an injectable form, short-acting. So a lot of the times, doctors are just going to go with like your typical B52, your Haldol shot. Whereas again, this is nice that we can kind of stay along the same lines of therapy and give them an IM short-acting Geodon shot. The dosing, remember, you're always going to give this twice a day with food. It's unacceptable to give this drug once a day because of the half-life. And because of the bioavailability, we want to make sure that you're spreading it out, giving it with food, minimizing the GI upset that occurs if you don't give it with food. So similar applies what we talked about in schizophrenia. Okay? hopefully that's just a nice reminder. Remember the active metabolite of this drug does have some norepinephrine effects. So again, this can be a little bit more stimulating, is why sometimes you won't get it at bedtime, and you get breakfast dinner in the daytime, okay? Not to say that you may have, of course, those patients that do disagree, I always want to mention that, and you would just potentially account for that if it did occur by giving potentially maybe a higher dose at bedtime, but typically you're going to split it up 50-50. So if they're on 160 milligrams, you're given 80, okay? Clinically, again, with that one, we also can go up to the 240, okay, for the milligram dosages on Geodon. Remember that the literature will show you that the maximum dosage is, the 80 milligrams BID. We'll sometimes give it TID, or we'll give the 80 milligrams, or we'll go up to, say, 120 milligrams twice a day, okay? So you might give 80 milligrams in the morning, and you might give the remainder to get up to 240 if you're going to do that later in the day. Depends on how that patient presents, but we typically try to keep it 50-50 overall. So if you're looking at exam questions, I'm not going to make it that confusing, but just know, you need to know it is a BID dose. Okay? Abilify, this one, particularly in bipolar, you'll notice that a lot of these have their indications going up to a higher dosage than some of the schizophrenia, and some of them are lower. So I know that's super fun to try and keep in mind. I'm not going to try to trip you up and say, what is the maximum dosage in bipolar versus schizophrenia? Keep an idea of the overall dosing parameters. Typically, if one is saying that it can go up to 30 milligrams, even if the max is 20, say, for bipolar and it's 30 in schizophrenia, we know clinically that that's going to go up to 30 because it's approved in another disorder. So I'm not going to be that tricky for you. But when we're looking most of the time at our schizophrenic patients for Abilify, we're usually looking at 10, 15, 20 milligrams being efficacious. Bipolar studies do go up to 30 milligrams in this drug. Okay? So that is a little bit of a difference. This one is kind of nice in terms of its efficacy in depressed patients. It is approved by itself for atypical depression, so you guys have probably seen some of those commercials on TV. Why everybody should start Abilify. It's the most amazing drug on the planet. It's for everyone. Everybody will feel fantastic when you take Abilify. We're still usually looking at it as an adjunct agent, even in those cases of using it in depression. Not to say that sometimes you might have that patient that can switch over to monotherapy, but in depression, again, it usually is adjunctive therapy, but if we're looking at, say, bipolar, it might be a nice monotherapy agent if you're not using, say, the lithium or the lamictal or some of the others. It does have some good studies behind it showing that it infuses monotherapy, especially our bipolar 2 patients. It is also is either suggested for those patients in the depressed phase, may be especially useful if you're switching to mania with an antidepressant. So I'm saying mania there, not even just hypomania. But, so that basically tells you that in our bipolar 1 patients, especially our rapid cyclers, it does help decrease the switch rate overall. Okay? Any questions on that? Is everybody clear? You're good? Yes? Okay. All right, so looking at our antipsychotics overall, I should mention, if you look at your article, there is some literature showing, say, acenapine, which is definitely something that may be coming up as more of a regular treatment. That's still something that we look at in terms of shorter-term therapy when most patients are going to be, in the acute manic phase that they'll sometimes use it. It's not something that if you look at the drug formulation by itself already, it's only available in orally disintegrated tablets. So that kind of tells you something. It's more for acute management and not for longer-term therapy. But you would expect, if we're talking about this, a majority of them, that all antipsychotics can be used. So, for example, like in the article I mentioned haloperidol, right? We know that that's Risperidol's baby, less of the issues of the side effects because the more steady concentrations you're having in the blood. So, if the active metabolite of Risperidol is 9-hydroxyrisperidone, and we're giving 9-hydroxyrisperidone, the company doesn't really have to go and do the bipolar studies as much in, though we know that the active metabolite is going to be effective, we can assume most clinicians are familiar enough with the drug that they're going to still use it in bipolar and expect it to have the efficacy. Okay? It would be nice if they did it so we could specifically say these dosages work well in bipolar patients, but it would kind of go along the same rule of thumb as in your Risperdal. The dosages in Risperdal, remember, in schizophrenia, typically you'll see going up to 8 milligrams, and bipolar they're going up to 6. So we may not need, we would expect with paliperidone to go up to, say, the maximum dosage of 12, where you might see that in your schizophrenic population. You might be fine at your 3 or your 6, or, if you had to, I guess up to 9. But I would expect in clinical practice, rule of thumb is we're usually pretty happy when they get to around 6 milligrams, at least on the dose of paliperidone. All antipsychotics, again, can be used, you would expect, even if they're not having an approval, have some efficacy. We try to use the ones that obviously do have the FDA approval, or, again, for something like paliperidone, kind of use our common sense to say that would be an all right agent to select. Okay? Remember, when we're talking about our benzodiazepines, ativan and clonopin are the two that we use. Again, remember, a benzo is a benzo is a benzo is a benzo, right? So if you're on a hospital formulary plan that particularly has a preferred agent that's somewhat longer acting, you might see them using that instead of clonopin, like they might use Valium, diazepam, okay? But typically these are the two that you're going to see used, especially more on the outpatient basis if you are going to be using them outpatients. And remember, these are going to be something that you're going to taper down. Definitely don't want to have a patient on them any longer than they need to be. Slow taper off of them, especially because of the high abuse potential of those drugs, okay? So that's basically, in a nutshell, for benzodiazepines. They are very effective, I should mention, in treating acutely for the availability of Ativan that we will usually give, Ativan, Lagavir, whatever you want to call it, in terms of the IM injections. With all of the agents that are available, short-acting, like say, are atypical antipsychotics. The other thing I should mention, you guys, we didn't spend as much of a focus on when we were talking about valproic acid, is that valproic acid is also something that we can give in a shorter acting injectable form. That's more so used for seizures. You won't see that as much for bipolar, okay? I want you guys to kind of remember, for acute agitation early on, you're thinking your atypical antipsychotics and a benzodiazepine. You're not thinking your lithium, your valproic acids, your lamictals, your carbamazepines, okay? Though they may come in those formulations, that's reserved for seizures. So don't get confused if you're going through the literature and see that those are available. If I were to say on an exam which would be appropriate, and I were to give you an IM injection of valproic acid, please don't select it, okay? Because you want to remember that that's not something that's appropriate in acute management of bipolar overall, okay? Calcium channel blockers are kind of one of those therapies that they themselves, because they're calcium channel blockers, you would expect to have some level of anticonvulsant effects. These might be something that if you do have a patient who's pregnant and you don't want to look at some of the other options that are available, is your first line in that patient. That really gets down to patient specificity. There's not always a right answer, right? Kind of what we remember from some of our schizophrenia cases we talked about. There's not always a great option, but these are much safer. Actually, if you guys know anything, if any of you have come across a female that has, blood pressure issues in their pregnancy, or even contraction issues, if they, are going into preterm labor and having contractions, they'll actually give nifedipine for that. So we know that's pretty safe if you have to do something in pregnancy. And it's got some studies out there showing that that's been beneficial. So again, not something I want you guys to be thinking of first line, but at least if we are having to look at those specific situations, there are options out there that we might use specifically in pregnancy especially, okay? When we're looking at our other antihypertensives, you guys will see clonidine and guanfacine, your centrally acting alpha agents. You'll see those when we're talking about ADHD next week as well. So I mentioned clonidine is kind of the oldie that's been much more studied. Guanfacine is another one in that class that's well used, and that one, because it did just come out for ADHD therapies in a longer-acting form. You may see some doctors using that as well, even though most of the studies have been done in quantity more so than quantity. Propranolol is another one that's actually what's called the stage fright drug. Did you guys learn about that at all when you were learning about anxiety disorders? Mm-hmm. Yeah, so as you would probably expect that in terms of some of the effects that we see patients presenting with bipolar, that we'll sometimes use that as an adjunct agent to help out with some of the anxiety, especially if you have somebody that we know is a rapid cycler and we're kind of leaning away from, say, antidepressant and depressed side, that we're going to switch them over. Or if they're in the manic side and having anxiety, obviously we're going to give antidepressants to those patients, but that might be a good option. Okay? The other anticonvulsants we've alluded to a couple times, so please remember these. Trileptal, we know, because overall, if you're going to be giving oxcarbazepine, or that drug in particular, the fact that it's got the less side effects, it ends up acting in the body pretty similarly to carbamazepine. That clinically, though it doesn't have the FDA approval, you're going to see it used. You should be aware of what that drug is. It doesn't have the FDA approval, remember that, but it's not going to be an inappropriate therapy if you were to see somebody on that and they're stabilized. That's absolutely fine, okay? The ones that I don't want you to remember as okay to use overall as a mood stabilizer, especially in monotherapy, okay, is gabapentin, topiramate, and tiagatamine. Now I'm saying especially in monotherapy, but I can tell you that Neurontin and Gabatril should not be used at all, really, in bipolar for mood disorder. As you guys may remember me mentioning, gabapentin specifically actually can cause hostile behavior. It's a common side effect of that drug in about 15% of patients. It hasn't even been in some studies shown up to 20 to 30% of patients. So we really don't want to be using gabapentin, and this was used off-label as a mood stabilizer. I still will get patients coming in on it, and I'm like, God, really? Nobody's caught this by now? Get them off of it, okay? Topiramate, remember the Topamax? You will sometimes see this used as an adjunctive therapy. It's not appropriate as a mood stabilizer by itself. Studies are definitely lacking on that. But because of some of the other side effects that it has of kind of just slowing down the person overall, there's specific reasons that psychiatrists may just look at this as an adjunctive agent to kind of bring the patient down. I mean, clinically, the medical literature behind it is telling you you probably shouldn't be using it. But I'm going to tell you that there are some cases that you're not going to win an argument with a psychiatrist that is using it specifically as a mood stabilizer for certain aspects of bipolar, okay? Rule of thumb, I can tell you several times I've broken out my medical literature and walked into a psychiatrist's office and said, you really need to suggest the idea of getting this person off of opioids, okay? Because the studies aren't there. The side effects outweigh probably the benefit. And until you can prove to me that this is really working, I would prefer to try an agent that we know does, okay? And then Gabatril. Sometimes, just because people look at the mechanisms of action of these drugs being an anti-epileptic and they kind of got thrown in there, not really efficacious. Now, it's interesting. Did you guys learn when you were going through your anxiety disorders anything about Lyrica? Okay, does anybody know what Lyrica is? You may have seen that one on commercial too. It usually treats fibromyalgia, right? That's also another adjunctive anti-epileptic drug. That drug in particular, in terms of your substance abuse patients, actually can be somewhat off-label. We'll use that. There's been studies that show that it has some of the same efficacy as lower-dose benzodiazepines. So, though I don't have that listed there, you're not going to use it as a mood stabilizer, okay? But you may see them sometimes in those patients that do have a history of substance abuse. Some psychiatrists have used Lyrica specifically for that purpose as opposed to a benzodiazepine. So that does have some rationale to do it, probably more so in anxiety disorders, but you will see sometimes that occurring in our bipolar patients as well, okay? And then remember the ECT, when everything else has failed, we've tried our refractory therapies is probably when we're looking at that. There are some psychiatrists that will use it earlier on in therapy, depending on what area, especially around the world that you're practicing in. Here in the U.S., we like to reserve it. Okay. So there isn't a perfect mood stabilizer yet. Remember, the gold standard is what? Lithium. Say it louder. What's the gold standard, guys? Lithium, right? Nothing's been proven more effective, but it sucks in terms of the side effect profile. We don't like it, right? So when we're talking about our acute mania, we're talking about potential to use it as an antidepressant, even as a monotherapy in our bipolar patients. Nothing's been shown more superior in it. You're looking at sometimes needing 3 or 4 meds to stabilize their mood, especially initially, and then we'll cut down on the adjunctive patients as they start going through treatment, right? You're always looking at the benefits versus risks, side effects, and outcomes of these patients. They need to be well informed, to know what they're getting into, why they need it. We really, really, really need to hone in on compliance with these patients, okay? Especially those that tend to be more of our cyclers, our rapid cyclers, more of those that are going to be bipolar 1 that kind of enjoy being bipolar 1, feel like they're more productive when they're manic. Right? So they need to know the overall risks and what they're really doing when that happens. And if you are having somebody that's more difficult to manage and more of your rapid cyclers, so more than 4 fluctuations or more cycles within a year, I want to make sure I nailed that down. I had a couple questions yesterday. You guys need to understand, rapid cyclers mean more than 4 episodes in a year. Okay? Now that's different from mixed bipolar disorder. Mixed bipolar disorder, remember I mentioned to you, is within a week they may be showing both sides of the disorder. So that's not what we normally would classify as our bipolar 1 or bipolar 2 patients. Mixed patients kind of go up and down and fluctuate. And that's not nearly as common in the majority of our patients. They're much more rare to come out with a mixed diagnosis. Okay. When we're looking at bipolar depressing side, remember lithium and lamictal are our 2 favorite mood stabilizers. When we're looking at mania, we're usually looking at your lithium, your other AEDs like your valproic acid, your carbamazepine, your lamictal, and if there are any more. So your lithium, your lamictal, your valproic acid, and your carbamazepine are the 4 you're generally going to remember, and then you're going to add your adjunctive therapy with your antipsychotic and your benzodiazepine in most cases if someone's acutely manic. Okay? So that'll help you try and keep that straight. Anytime you do have somebody experiencing psychosis, remember, we're not typically going to see as often of starting out with an antipsychotic in our bipolar 2 side. You may, especially if they don't want to try, say, the lithium or the lamictal because of the risks associated. But the rare occasion of you having someone who does dip into a psychosis, if they're severely depressed, and remember, our bipolar 2 patients have more of a severe depression, and it lasts longer than our bipolar 1 patients. If they are untreated for more than 2 weeks, and you have that severely depressed patient going into the psychotic phase, you then, of course, would be looking at your mood stabilizer and adjunctive therapy with your antipsychotic, okay? Or maybe even just using your antipsychotic if for whatever reason you couldn't use the lithium or the other couple AEDs, okay? Are there any other questions I can go over right now to help get rid of some of the fuzzier gray areas? Are we okay?
In terms of the progressivity of bipolar,
Progression.
The manic episodes progress, the severity, the frequency more so than there is in total rapid cyclers.
It can get worse over time. It's not the same rule of thought as, say, schizophrenia. We know every time they have an episode, it definitely causes the disease to progress more and more. But what we'll see is, in terms of the progression of the disease, it can bring them into having episodes more often.